Welcome, McCall. I am so excited to have you here today. This is a very hot topic, one of the hottest topics I could probably have a guest on for. So, we will be talking all about semaglutides, and also we'll be talking a little bit about thyroid health, as you are a thyroid expert. And I collaborate quite a bit with Cynthia Thurlow, and I'm not on the front lines anymore. I'm not in the clinic. Yes, I know a lot about semaglutides, and a lot of my students are asking about it, but I'm just not in the trenches anymore. So, do you have an expert for me? And she recommended you. So, anyone Cynthia recommends, I'm like, all right, she's got to be good. She's got to be really knowledgeable. So, welcome to the podcast. So happy to have you here.
Thanks. I'm so excited to be here, and we've got some great topics to discuss. So I'm
Yes,
excited. Thanks for having me.
definitely do. So before we hop into our topic, just give us a really brief overview of your backstory and how you got to be so interested in thyroid health.
Yeah, so I am a thyroid expert by way of being a patient. I'm a practicing physician assistant, and really when I was 27 was debilitated with my own thyroid disorder and simply could not get it appropriately addressed in the conventional medical model. So was really the better part of a year going to bed at 3:30 in the afternoon every day. Eventually, I ran into one of the only integrative medicine physicians in Austin back then that knew about thyroid. And within a few months, he gave me my life back, very, very quickly became a mentor to me. And now I get to do that in my day job. I get to impact the lives of people, but mainly women, and give them back their lives when no one else has been able to. So it's a pretty rewarding, it's a win-win for sure.
Yes, beautiful. And I have so many students who have thyroid issues working with insulin resistance. They're just so interconnected. And before we hop into the semaglutides, I do want to just ask, because I work with people with metabolic health issues all on the spectrum, from just kind of starting to very, very ill, and type 2 diabetics, up to the level of insulin, and a lot of insulin. And a lot of what I teach is intermittent fasting protocols, but also just time restricted eating and getting away from snacking and focusing on meals and focusing on protein. But what are your thoughts? Because I get almost on the daily, like, I have hypothyroidism, or my thyroid doesn't function optimally. I've been told I can't fast. And it's just a very general umbrella. Like, my doctor told me I can't
Yeah.
fast. What are your thoughts on that? And of course, we want to keep this individual,
Yeah.
and everybody is going to be different, but it's just so irritating to me when people are like, nope, can't fast. Like, I have a thyroid issue, or I'm hypothyroid. So let's hear from the expert what you typically recommend in that area.
Yes. So it's almost, sometimes in medicine, these old wives' tales, they just get passed down, propagated, repeated, regurgitated without a whole lot of truth to them. And this is absolutely one of those cases. Obviously, I can't make a blanket statement like you said, but what people get so fixated on is people with thyroid conditions often have adrenal conditions, and people with adrenal conditions can't fast. The reality is this, like, intermittent fasting, time restricted eating is one of the most powerful tools for these people with metabolic dysfunction, metabolic damage from prolonged hypothyroidism. It's one of the most powerful ways that, in terms of lifestyle, they can unravel that damage. And what I tell my patients, because I also get this question almost every day, is look, sure, does your body become a little bit stressed when you intermittent fast? Theoretically, sure. You know what really makes our body stressed? Having to break down food all day, every day, and it being in this constant state of inflammation from dealing with food all the time. So is there a trade-off? Absolutely. But when we're able to potently not only unravel the damage metabolically that we're dealing with on a day-to-day basis, but also walk around a heck of a lot less inflamed. If we weigh the risk versus the benefit, and medicine is always about risk versus benefit, that's, the pros outweigh the cons. And you don't have to go to extremes, right? We don't have to be fasting 3 days a week in terms of 24-hour fast. We don't have to intermittent fast every day, 20 hours. But if everything we do is sort of in balance, there's a lot of impacts to people's long-term health with thyroid conditions with intermittent fasting.
Wow, it's almost like I was whispering in your ear what to say. That's exactly what I tell people, so I'm glad we're in line with that.
Yeah.
So let's transition over into semaglutides, and in particular, people are like, "What the heck are they even talking about?" Ozempic, Wegovy, they're all kind of under. I believe it's the same company that makes all of them. There's just different indications. So let's transition into that topic and tell us a little bit about what they are and how they work. I know like that is even just a big question, but what it is that they're doing physiologically for what they're indicated for.
Yeah. So, if we think about them as a whole, we're thinking about a class of medication called GLP-1 agonists. And they are the exact drugs you named: Mounjaro, Wegovy, Ozempic, semaglutide, Saxenda, those sorts of things. So they have been used for almost 20 years for diabetes. But what ended up happening is we started noticing in the studies for diabetics, hey, these people are like losing a lot of weight. So now obviously they're being studied for weight loss with diabetics, and even now weight loss in and of itself. I definitely think they play a huge role in the thyroid community, but they impact our weight, our metabolism in a couple different ways. One is miraculously, to strange, profound effects, they reduce our cravings. So it could be for food, it could be for snacks, it could be for sugar. Now they're looking at it for addictive behavior, even with smoking, alcohol. They just curb the craving seeking behavior. They make us feel fuller sooner. And they make us eat less. They make us feel fuller longer. So obviously there's this total caloric reduction that happens. But I tell my patients, look, like if you actually didn't change your caloric intake at all, these medicines still allow you to lose weight, because when your blood sugar peaks above optimal levels, it starts to take excess blood sugar and pull it out and neutralize it in our bloodstream. So we're not spending so much time in this phase of our body telling us to store fat, right? We've got all this extra sugar, let's store fat, let's save stores for later. So that too impacts people's ability to lose weight, especially in the community of metabolically damaged people that often are walking around and they're already eating less. They can't really restrict more calories. They can't eat better, and that is a lot of my patient population, is those women who the input does not equal the outcome because of their metabolic dysregulation.
Sure. So when we're talking thyroid patients or those with suboptimal thyroid function, I know and correct me if I'm wrong, I think it's Wegovy that is the newer indication is for a BMI of 27. And was it Ozempic that was for type 2 diabetes plus the BMI? I might be switching them up, but with thyroid patients, is that still the case? Like, is the hypothyroidism considered a comorbidity and they still have to have a BMI of 27? Or what are the overall indications? Because I know, one of the biggest downfalls or the biggest struggles that I'm seeing in the community right now with my students too is that people are frustrated because those who are who truly need this drug and they can't get access because it's been being sold to people who want to just lose 5 to 10 pounds to go on spring break, or whoever it is who's getting it sold to them underground or in the black market. So what are the indications the same for thyroid patients, and are you seeing trouble with access to these drugs?
Yeah, so I kind of look at it in two different ways. I look at it as people with pretty significant, profound, high BMIs, and those people use brand name drugs. They have access to those brand name drugs. They can often get them approved by insurance. And I really think that that is where the insurance-based model addresses chronic disease, like in our country with this class of medication, but I actually have a bit of a different view on the compounded higher access people, in that I actually do advocate for the people that, hey, they might only have 10 to 20 pounds to lose, but there is nothing that they can actually do to lose that weight. And that's not everyone. Sometimes it's simply people won't put in the work. But my kind of subset of patients that I deal with, especially with thyroid, especially in Austin, where my patients are healthy, they like work hard in their lifestyle, they exercise, they eat well, they eat a low inflammatory diet, they can't lose weight. They can't lose 2 pounds over 5 years, even with perfect thyroid function. And so I view this class of medication in the off-label prescribing of it, in the compounded non-insurance based model, as being actually appropriate for this class of people, not just to lose weight. Sure, that's a great thing. When women lose weight, they're happy. It makes a big impact on our quality of life. But actually, they start to heal the metabolic damage that happens with hypothyroidism, with chronic loss of that metabolic potency, so that these people come off of these medications and then they put appropriate levels of work into their lifestyle, and they're able to maintain, they're able to lose weight in the future if they need. They're not stuck in that metabolic dysregulation state.
Right. And that's important to differentiate. Like, we're not talking about people who are going through fast food drive through 10 times a
Yeah.
day, or drinking 6 sodas, and expecting to just take an injection and have that all go away. We're talking about, like you said, like women who have tried for years, decades to lose weight, have done all the things that you and I would recommend, and still struggling. So tell me about the compounding. Until I started to watch some of your videos, I didn't realize that semaglutides could be compounded. I guess I think when I think of a compound pharmacy, I think of, like more of the powders or the capsules that are being compounded. I didn't realize that this could be compounded. So how do you, and maybe just explain a little bit about what that process is and what it means? Because I know
Yeah.
before I had an ill family member, I had no idea what it meant to compound a
Yeah.
medication. I'm like, so tell us about that process and how what dosage to start with, and how you're, what kind of results you're seeing with that.
Yeah. So great question, by the way, because you're right. So many people aren't familiar with compounding pharmacies, especially not in this case. Compounding pharmacies are unique in that they either take, medications, and they're able to break them down into microdoses, and they create a medication for each individual patient at whatever the provider needs. So for example, low dose naltrexone, which has, a lot of longevity studies behind it. They take naltrexone at 50 milligrams and they make it down to 1.5, so it's customizable. There's a subset of compounding pharmacies that are sterile, and this is actually very hard. They meet very rigorous qualifications to be able to make injectable vitamins, nutrients, peptides, medications, and they are able to take the peptide of these GLP-1 agonists, because at their core, they're actually just a peptide. They're just strings of amino acids, and they are able to combine them with, my pharmacy uses NAD, which is a very, very potent anti-inflammatory, anti-aging, mitochondrial support nutrient. And they're able to use these medications in a way that are separate from creating shortages for people that need access to these medications with diabetes. This is a completely separate supply, and physicians, clinicians are able to prescribe them with people in unique amounts, quantities. It's no longer a preloaded pen. So people get all these side effects from too much at once. You can't do anything with preloaded pens that are covered under insurance. With compounds, you can adjust doses and nuances. You can tailor, specific regimens to people, and not have this one size fits all regimen that comes with the current paradigm of the insurance-based model for these meds. So it has definite advantages. I'm seeing lives completely changed, and again, like, I know everyone tends to focus on the weight, and to a fault, I almost don't focus on the weight. I focus on, hey, these women that have disordered eating because they're having to overly restrict to maintain their weight are freed of that. their metabolism is fixed, like the things that I'm seeing on lab markers with people on this class of medication is absolutely mind-blowing. Like it just will change their long-term health outcomes for forever.
That's really interesting. I know, like I said, I wouldn't think that it would have been something that you could compound. And you mentioned LDN or low dose naltrexone.
Mhm.
And that's actually how I found out about compounding, because one of my children who was really ill, we tried that for a while. And then my daughter, who was diagnosed with PCOS a year ago, has been taking that, and it's been game changing. But anyway, that's super interesting. And you would think that more healthcare providers would, and maybe I just don't know, because again, I'm not in the trenches, but you would think more healthcare providers who are diagnosing and treating with semaglutide would do more compounding. And then, like you said, like you don't even think of the shortage, you can kind of bypass that whole issue. That's really interesting. So what are the standard dosages, and then where do you start? Because I think, like you said, a lot of the problem, we'll talk about side effects, but a lot of the problem is, like just with my community, the couple of questions that I've posted about this, like, have you tried it? What are your thoughts? And just staying really neutral to see what the thought process is out there is like, no, I would never do it. Or I did it and I got so nauseous from one injection that I'll never go back to it again. And then of course there's a lot of positive feedback as well. Like, yeah, it's worked really well for me. But I would say probably the biggest reason people don't take it or discontinue it is because they get really nauseous. They get digestive issues. And, is that something that you see more as a dosage issue, or is it just some people are going to react to that no matter what the dose is?
100% dosing issue. I'm not 100. There's maybe less than 1% of people that just doesn't, their physiology can't tolerate it. But it's so strange. I even have patients switch from injecting the medication in their stomach to their outer thigh. That alone cures a huge amount of the nausea. But we'll start in terms of our compounding dosing at normal doses, the same doses that follow, prescription insurance-based semaglutide. But after week 1, if people are nauseous, we either reduce their dose in half and then have them inject it separately, like once on a Monday, once on a Thursday, because most people will get nauseous as it peaks 24 to 48 hours after they take it. And that too keeps people from getting nauseous. So I've taken about 300 people through our weight loss program at Modern Thyroid Clinic. And I would say, I think I've had one that stopped it because of side effects. So extremely well tolerated when it's not this one size fits all approach. I think that that's a pretty common side effect with just the standardization of it all. But if you can access compounding forms of it, and that's what I so encourage people is, look, like if you can't get it approved and you're trying to pay $1,400 a month for this medication, there's other ways of doing it. There's better ways to access it, because the reality is insurance does not want to pay for these. It's expensive for us. It's very expensive for them as well. It's $20,000 for them every year. And these companies want people to stay on this forever. They don't want to make that kind of commitment. They don't want to pay. They're a business. They don't want to pay that kind of money. So you have to learn to kind of advocate for yourself, and yeah.
Yeah, it is expensive. So, what about, so you brought up like the companies who make the semaglutides, of course, want you on it forever, and what pharma company wouldn't want you on any kind of medication forever? But what are your thoughts around that? Because I've heard so many different things here too, like, oh, just do it for 3 to 6 months, kind of as a, just to kind of get you in the weight loss mode, and like you said, kind of brew up the metabolic potency a little bit, get that kind of jump started. And then I've heard, nope, like if you start it, you need to be on it long term. You can never come off of it. And then we can talk about, what you're seeing when people are coming off of it. But what are you recommending? Is that very individualized too? Does it depend on, the disease process, or, where are you at with short-term versus long-term? Because I have heard so much conflicting information with that.
I completely agree. And I think there is a dialogue that's being fed and emphasized and overemphasized that these people need to be on this forever. And I think that absolutely 100% is coming from insurance. I mean, not even insurance, excuse me, the pharmaceutical company. So and my patient population is very specific, right? So my patient population is 99% women who have thyroid dysfunction for years, decades. Their metabolism is ruined. We perfect their thyroid function, unlike most people have access to in general thyroid care. We have a very, very unique approach. So we solve the problem that creates the loss of metabolic potency and weight gain. So, before these people are on these medications, the cause of their metabolic dysfunction is fixed. So in my patient population, they do not stay on these medications. So they will cycle on and off of them until they reach their goal weight. And really, more importantly, until I see signs in their blood work that their metabolic potency is restored and that they can live life reasonably, eat reasonably, exercise reasonably, and be able to maintain their weight. And then they come off. So I do think there's patients outside of Modern Thyroid Clinic with chronic obesity and a thyroid problem that's actually never fixed. So if they come off of these medications, slowly that loss of metabolic potency will simply recur. But very, very rarely. The only people that I plan to keep on this medication are people that it's really been absolutely life-changing for their inflammatory process, for their disordered eating, and that would be just a micro dose for longevity purposes.
Sure. So what signs are you looking for to see that their metabolic potency has been restored? Is it mostly lab work, symptoms, a little bit of both?
It's definitely lab work. So I'm a neurotic data person. So we check labs before people start the medication, and we check them every 3 months throughout the program. And, I want to see their hemoglobin A1C very, very low, very sensitive, with room to swing up 0.1 or 0.2 points. So I really like their hemoglobin A1C to be down to about 5.0. And I want their fasting insulin to be 6 or less. There are people that I'll be okay with less than 10, people that started in pretty high levels. But I really want to see that functional blood sugar metabolism restored to a pretty tightly controlled zone before I pull people off.
Okay. Yeah. And I would imagine when your insulin is that low, like I always say 2 to 6 as a long-term goal. But you're right. It's like sometimes if they're starting at 30, it's like, well, you
Mhm.
get down to 15, you're halfway there. And then the hemoglobin A1C, I always say, like, I like to see under 5.1. So, and not even on the medication as a long-term goal. So yeah, that's kind of right in line with what I'm looking for with blood work as well. So have you seen, and maybe it hasn't been long enough because I know, you know, the medications have been around for 20 years, but they've really just been with that newer indication of the BMI that's been over the last couple of years. Have you seen a lot of side effects or people having issues with weight regain when they're coming off? Or is that where you say, okay, let's just do a real small microdose so that you don't see those issues?
Actually, I'm not seeing weight regain.
Okay.
So, I'm about a year and a half into to sending my patients for it or prescribing it myself. So, I've got it. I don't have 10 years, but I definitely have enough data at this point to say, listen, I actually do not expect you to regain all of this weight when you stop this medication. Again, my patients, they're health conscious. They put effort into their lifestyle. They're not eating fast food 3 days a week or 5 days a week, however often. They're definitely health conscious. They work for it. But the key to me is I want women to put in an appropriate amount of work to maintain their weight. I don't want women having to live in this tiny box and revolve their whole life around food and exercise to not gain weight. That's just inappropriate. It's not fair. It's not physiologically normal. So we're definitely meeting that goal.
Good. And have you seen improvements in thyroid function with this medication, or do you think that that's just, something that that they're not really correlated, or have you seen thyroid function improve with it?
Definitely. So, you know, I'm seeing people's Hashimoto's antibodies reduce. So I'm actually seeing, because of this reduction in inflammation that these medications cause, I'm now seeing people's antibodies reduce, head more towards remission for their Hashimoto's. And then obviously too, as people lose weight, their demand for thyroid hormones reduce. And so people are actually able to reduce their medication. A huge, huge percentage of people just simply will need less medication as they move through the program, which is really a win-win.
Yeah. And I think that just you having a program set up is, I mean, that's critical. So, what else are your patients learning in that program? Because, again, and I've seen a lot of positives, but the negatives that I have in my head are people who are taking it just because it's
Yeah.
available and they
Yeah.
want some quick weight loss without putting any work in, not changing their lifestyle. That's one of the negatives. And then the other thing that I wonder about, that I look at, where there's been a few studies that have shown people losing muscle mass with it.
Mhm.
We can talk a little bit more about that, but it's critical. Like, I feel like I just love how you have it, because you have to learn the foundations of good nutrition and, building muscle through exercise, or at least preserving the muscle mass that you have, and making sleep foundational and all of those things. So are you addressing all of those things along with it? I would imagine, in your program. And that's probably, I would imagine, why your patients are so successful if they have come off.
Yeah, I mean, I do agree. I think there's a huge percentage of people that get access to this medication and then they're like left on their own. Like, no one is teaching them what to eat, how to exercise. No one's there to answer their questions. They're just left to their own devices. That's definitely what I'm seeing more often than not. And yeah, no, our program, it really is all encompassing. We definitely emphasize, hey, you have to work on building muscle during this process. We break essentially from any and all cardio exercise I ask them to throughout the program. And hey, we work on building lean muscle mass, preserving that lean muscle mass, eating in a way that will do that. And that's with a lot of intention. When these people sometimes are having a difficult time getting enough food in, they need to be instructed in a lifestyle way to help them be set up for success during the program, but also long-term success whenever they come off of the medication. So yeah, we talk about all that. We have like weekly meetings and we have discussions about a topic of, lifestyle, nutrition, workarounds for getting enough micronutrients, all those types of things. So yeah, I do think that definitely plays a role in our success. And yeah.
Yeah. And are you actually measuring body composition, or having patients get a DEXA scan or anything, just to kind of monitor that muscle mass?
I wish that it was built into our program. Like, I wish we had a DEXA scan at Modern Thyroid Clinic. We don't. I encourage people to do it, but it is less intentional and with less predictability than other weight loss programs that build that in, which I love.
Yeah, I know. And I mean, I'm out of my home, but we didn't have the clinics that I've worked into. There wasn't a DEXA scan available. I would have to send them to a bigger institution, but that is a really great way to just kind of monitoring that muscle mass. But and then just focusing on the protein intake, and making sure that strength training is in there as well. So just kind of circling back to the cost, because I know that prohibits a lot of people. So the cost, I think, is roughly $1,200 per month or so, as a prescription. What about the compounding? Like, what is the cost difference there? Is it a lot more affordable to do it that way? And then, is that something you could ask your provider about? And if they have no idea about it, like, how would you get more information about that? Because I'm sure I'll get that question.
Absolutely. So yeah, the prescription with insurance based model is about 12, honestly, more like 1,600, 1,400, 1,600 on average per month. With most compounding forms, it's usually around 400 a month. It'll deviate slightly either way, but I would say that's a pretty good average for semaglutide. For tirzepatide, it's more expensive for sure, but I definitely encourage people to look into the semaglutide option. Most physicians, most standard clinicians do not have accounts at compounding pharmacies, particularly sterile ones, because they're kind of few and far between. They really are. It's just very hard for them to get that licensing. So what I would encourage people to do for access is most places have weight loss. Most cities, towns will have a weight loss program similar to ours, maybe with a little bit less support, but still, where you can go to, a physician that maybe is a plastic surgeon, or a medical spa that has nurse practitioners, PAs, MDs, those places. And they usually will have a weight loss program based around compounded forms of this, that you just pay out of pocket. It's a predictable fee. You know what you're getting, you know what you're paying. And so really, if you dig around and look around, access is reasonably readily available for the compounded forms of these medications.
Yeah, and that's a substantial, I mean, that's like 25% of what you're paying for, probably, something that's tailored to you and going to work much better in your body. So I'm sure people are gonna start to catch on to this, and hopefully that'll be a positive thing. Any other contraindications that you see, that people can't take these medications for? You mentioned they're a peptide, so they're a protein, which is why you have to inject them. They're basically would be destroyed by your stomach acid, I would imagine, if you, which is why we can't take them orally. But any other contraindications where you'd see like, no, this is just not right for you?
Definitely. So, overt contraindications are history of medullary thyroid carcinoma, history of thyroid cancer in general. I'm very, very cautious. History of multiple endocrine neoplasia, which is another form of endocrine cancer. People who are on insulin need to have very, very in-depth conversations with their endocrinologist. I do not recommend it for women who are actively pregnancy planning anytime in the next 6 months. I like there to be a lot of space in between being on these medications in pregnancy, just because they're not studied, and I'm crazy about my pregnant ladies.
Yes.
I
You need
definitely think
to
it
be.
can, right. I think it can help with fertility, but we need to leave like a very solid buffer. Definitely history of pancreatitis, pancreatic cancers, contraindication, but largely, I mean, they are pretty well tolerated. There's not a lot of contraindications. People are always worried, well, what if I take Advil? Can I, like, it's very free and fluid, not a lot of restrictions as far as those things.
Okay, that's good to know. And how do we know the difference? So there's all kinds of different, I mean, they're all in the same class of semaglutides, but how do you know, like, oh, I need the Ozempic, I need Wegovy, I need, how do
Yeah.
you know? Is it indication wise? Is it dosage? I know some are, dosed daily, which I would imagine many people would want to do. Some are more weekly. How do you know which one is right for you? And, how do people go about, asking for this?
Yeah. So definitely, I think when you're an insurance-based model, when you're trying to get it covered with insurance, it is the indications that your insurance will approve, and your doctor will specifically be able to guide you through, hey, this one would be the most likely, we should try this one versus this one, or this one has a current coupon. Like, it really is about navigating the system. Almost, it's so much of just hoops that people are jumping through. As far as when we think about what they are at their core and who does better with what, I'd say there's two main classes. One is the semaglutide based, and one is the tirzepatide based, which is more the Mounjaro. And really, I think most people, because of access and pricing, should gear towards the semaglutide. People who are resistant to weight loss with semaglutide, or are very, very intensely having side effects, should then look at the tirzepatide form, because it has a little bit more weight loss and a little bit less side effects, but access can be harder, definitely more expensive, that kind of thing.
Yeah, I didn't even realize there were so many, 3 or 4 And it's just crazy. But does the same company, the same pharmaceutical company own all of them? I
You
can't
know
remember.
what? I think that there's two main pharmaceutical companies, but I could be wrong. I could be wrong. Yeah.
Okay. Yeah, interesting. Well, I'm sure we'll see more and more coming out,
Oh, yeah.
unless, there's always the patent thing and all of that everything revolves around. But yeah, it's super interesting. I've learned a lot today. Any other health, like long-term health markers that you're seeing, or like is really kind of your goal for your patients? We talked a little bit about like the lab work with the insulin and the hemoglobin A1C. Any other real beneficial long-term health markers that you're seeing with the patients that you're working with?
Absolutely. That is such a great question. It's honestly the most exciting part for me about these medications. And it's something that I had read in the studies before we started our program, but I didn't really know how much to expect a shift. And that is a marker called HSCRP. Okay. So it's an inflammatory marker. So it will tell us kind of general inflammation. It will tell us cardiac inflammation, but more than that, it risk stratifies the likelihood that in the future we'll have a cardiac event like a heart attack or a stroke. So for both men and women, heart disease is our number one killer by far, the number one cause of death and disease in our country. What I am seeing with people's HSCRP is absolutely profoundly life-changing for their long-term health outcomes. So we check it before we start, and then we check it every 3 months. And to give listeners a little bit of an idea, ideally you want it less than 1, even less than 0.3. That's a low risk for cardiac event in the future. 1 to 3 is an average risk. Above 3 is an elevated risk. Obviously, the higher you go, the more the risk. Well, I am every day seeing people whose CRP started at 10 get less than 1, who started at 25, less than 1, 35, less than 1 in 3 months, which you're hard pressed to find someone with a CRP of 35. It's pretty extreme risk for cardiac events in the future. There is no other way, even as a functional medicine clinician that works on inflammation, there is no other way that I could replicate this result with anything else. Nothing, not LDN, no diet, no lifestyle can get a person with a CRP of 30 to less than 1 in 3 months. So I'm seeing the CRP remain low even after they discontinue medication. So basically we're taking people from extremely high risk of the number one killer in our country and making them in a low risk category in a very short period of time, which is pretty impressive and profound.
Yeah, that's amazing. When my son was so ill, he was only 11 and 12 years old when we had these tests run, but one time his CRP was 12, one time it was 20. And we're like, oh, and it's just a general inflammation. I mean, obviously he had no cardiac issues at that time, or there were more digestive issues, but it is scary to see that so elevated. And a lot of times people just don't know, like, it's general, but it's like, where is the inflammation? Where is it coming from? How can I fix it? And even if you have the means, or you have the knowledge, or you have the motivation to fix it, it's just like, okay, it's still elevated. It's still at 7 or 8. So that's very encouraging. And that's another thing that I don't think is emphasized very often. And maybe it's not even being checked, and it's not being checked very regularly. And I always, when people start my program, I always encourage them to get that CRP done as well, just so we can kind of see what it's looking at. But anything else that we didn't talk about with this class of medications that you want people to know that you're seeing? I mean, we talked about dosage and side effects and cost and how to get it and what it's doing. Anything else that we didn't touch on?
No, I mean, the thing that I really do like to emphasize that to me is, the CRP. And then the one other thing that makes me really, really excited, honestly, is just the food freedom that it creates for women, the healing that I see from disordered eating patterns of even the healthiest people just having to overly restrict for so long. I think it has a unique ability to change that path, especially for women. And so that has been the most surprising piece to all of this throughout my learning and experiencing this with my patients. So I find that extremely encouraging too. And for me as a clinician and seeing this freedom that is happening with these women and almost disordered eating being healed to the impact that it's making on their life too. So
Yeah, and both of us are dealing with and working with people who are very ill and have been ill for a really long time and have tried all the things, it's like, or at least, you know, for me, I'm always like, okay, let's make sure you've hit all your foundations, but then there's always, you always have that subset of people who are like, I'm doing all the things, I'm doing all the things you recommend. And they see maybe 50, 60, 70% healing, but they're just not to that place where they just feel, like you said, feel great and don't have to think about food. And, it's just not this black cloud hanging over their head. So,
you don't have to feel guilty every time they
yeah,
eat
yes,
healthy, food,
yeah,
right? Which is just not the goal that we want, to propagate. We want people to eat nourishing food, enjoy it, not feel guilty about it, let it serve their body. And there is a subset of women, especially that just have lost the ability to do that.
right. Yes, couldn't agree more. Okay, so you work with Modern Thyroid Clinic. I'm sure people are like, okay, how do I work with McCall? And do I have to move to Austin to work with her, or do you do your program online? So tell us about your program, and if people, you can't just prescribe, I wouldn't imagine, these medications to just anybody. They'd have to work with you. But tell us about that process. And if you're not able to take patients, maybe where an alternative could be.
Yeah, so lots of exciting things happening there actually. So we can see patients in Texas, generally telemedicine, period. So you don't even have to physically come to Austin. Our out of state patients right now fly in for one appointment, and then everything else is done virtual thereafter. We do not take patients for our weight loss program that are not our patients. It's not like an open thing that just anyone can sign up for. It's definitely, it's our little community of people. I guess our community isn't so little anymore, but yes. And so that is kind of how we're set up now for out-of-state patients. What's happening with Modern Thyroid Clinic at this moment in time is we are actually working on expanding nationwide. So we are working to increase access to all states. That is actively starting now. So every week we're getting closer. We're rolling out state by state. People can sign up to be notified when we make it on their state, and also tell us to come to their state sooner because we're rolling out according to need and demand. You can find all of that in the link in any social media that I have, and it's just our out of state wait list. So you can sign up and I'll let you know when we make it to your state, which is so exciting. The most exciting thing that's happened in the last few years for us. So we're excited to help more people and expand our reach easier.
Yeah, that is exciting. And that's just, you know, for you to say that, it's like, it just brings it to the forefront. Like, people need this information. People are ill. Like, people have sought you out. People have sought your clinic out, need this information, and they need healing and
Oh,
to feel better. So that's very exciting. And, I'm sure my listeners are loving that you are saying that. So do you also have a course, or,
yeah.
that people can access?
I absolutely do. Great point. So I do have a course. It's called Thyroid Empowered. And really, I created it for all the people that can't become a patient of Modern Thyroid Clinic. It takes you through everything that you need to know about your thyroid, lifestyle, how to reverse your Hashimoto's, what your hormones mean, what your medications mean, if they're working for you. And it sort of builds up to this culmination of us getting lab work done and then me having a consult with you in a group form, which has honestly been so incredible. And I kind of give people, hey, this is my take on what's happening with your thyroid. If you were my patient, this is what I do. And they can take that information and go back to their doctor and have a discussion. And we've cycled through it twice now because because we have the consult, it's a set schedule, and it's just, the feedback's been incredible. And I really do think we're empowering people. So it's pretty special.
I love that. I know I stopped. It's getting to the point where I was working one-on-one with people. I'm like, okay, I'm telling not every person, but the same things. I'm like explaining the same things over and
Right.
over. And I really I need like 20 sessions with you to really get
Yeah.
to the point where I know you know everything I want you to know and to implement. So I'm like, I'm just recording a course and then they can go and learn it on their own. So those courses are very valuable. I love them. I love that you can go and, just do it self-paced and know that everybody's getting the information that they need in a course form. So, the websites, are they the same to find the information, or where should we find you?
Yeah, so you can find my courses at mccallmcpherson.com/courses. Again, it's all linked in my social media, Thyroid Empowered course for sure. But yes, modernthyroidclinic.com and McCall If you like social media, TikTok is my favorite place. So find me there.
Excellent. Thank you so much for coming on. We'll link all of that in the show notes. I have to say TikTok is not my favorite. I'm more of an Instagram person just because I just never really figured that TikTok platform out, but I'll keep trying. So thanks so much for your time today and all of this information. I know I learned a ton, so I know my listeners did too. Thanks so much.
Thanks for having me. I really enjoyed it.